Hello and welcome to TruST TV. I'm Ruth Rogers. So the news this week right across the UK is that we're looking at standing down many of the social restrictions in place as a result of COVID-19, but we're still seeing stubbornly high levels of infection in our community here in the Southern Trust, as well as in our hospitals. So I suppose the question that we're all asking is, when will this pandemic actually end and we can get back to normal? So to talk about this, we have three leading experts in the field of infection prevention and control, or IPC, as we call it for short. We're joined today by Paula Rehse, who's the Technical Officer for IPC, who's based in the Regional Office for Europe for the World Health Organization, Dr. Nizam Damani, who we know is a global expert in the field of IPC, and an advisor to many organisations, governments, countries, and of course, the World Health Organization, and our very own Trudy Reid, an Assistant Director in the Southern Trust and our lead on IPC. You're all very welcome.
Thank you.
Thank you for joining me this morning. Paula, can I come to you first? Is it the beginning of the end of this pandemic? Are we actually turning a corner with it?
Hi, Ruth, and hi, everyone. So it's a great pleasure to be with you here again. And I'm also happy that we keep talking about infection prevention control, which is not only the area I work and I dedicate part of my life, but also an area that is important for all patients, all health workers, and also visitors. I wish I would have the answer to say, yes, we are very close to the end, and say as of, let's say, 1st of April, life is back to normal. Unfortunately, none of us know that, right? We see and we are following that how the pandemic is behaving, right, since its beginning. And I think there is still a lot to happen, especially in the European region. We still have many countries in the European region. I'm not talking about EU countries, but the region that we cover here, that they do have very low vaccination coverage. Right? While in the EU, we see, most of countries, increasing and getting very up the vaccination coverage. Unfortunately, the situation is not the same across all countries in our region. So we say that, the pandemic will end when it stops everywhere. So right now, it doesn't seem that it's stopping really everywhere. So it's still happening a lot in many countries. But I think that we as individuals, we all wanted this thing to end, right? It's been so long. And then we talk about how many years it took from our lives, right? From our families, from our, the things that we would like to do and we couldn't. And I would like that we make a pause just, to reflect that unfortunately, many millions of lives were affected by this pandemic. And while we are and it's a very genuine, a very legitimate wish, we need this to end and go back to normal. For millions of people around this, this world, life will never be the same again. And I think that this is, especially when we work in infection prevention control, always someone that had sepsis in the hospital and then was, had a long-term infection caused by pathogen that is resistant to most of the antibiotics. And the life of that person and the family and the friends, it changed. So I understand as an individual, because I'm also part of this planet, I also would like to go back to normal, but life is never back to what it was before. We always lose something every day. So I would like people to, if I can give a message, is like we have to find a way to live in harmony, right? Because things always change. And if we're close to the end, great. If we are not close to the end, great too, because we still have many things that we as individuals we can do to end this pandemic.
So we all have a responsibility then. individually to take us closer to that end. Dr. Damani, if I come to you, here in the Southern Trust, we are still seeing really stubbornly high numbers of infections in our local population. But will this then result in higher levels of immunity for us in due course? Or have we even reached herd immunity? And what will that mean for us then in the coming weeks and months?
Okay, so I want to give you a bad news and a good news. So let me get over the bad news, and then I will talk about the good news. The bad news, I think the Omicron, as you know, is highly transmissible.
Mm-hmm.
You can see the number of cases have gone up a lot. That's because of increased transmissibility, but also because I think we were actually testing more, especially in the United Kingdom. So some countries were testing more. So I think that partly that reason can be a little bit low, but that was the main reason. The good news, I think, is that we have to understand that we are now bridging over from what we describe the acute phase of pandemic into endemic. And when this is going to happen, I think it's going to happen very slowly and gradually. But as Paula has already highlighted, the life will never be normal. One thing certain is life is change. Nothing is permanent except change, okay? So we will enter into what we call new norm. The good news, I think, about it is there are three bits. First, Omicron, we have seen the number of cases, mostly they are mild. And the number of people who are translated into hospitalization and severe infection are much less than Delta variant. They are there, but they are much less. Second issue, I think, around here is that Omicron have infected so many people. So what we have, what we call hybrid immunity. That means the vaccine is actually giving you immunity, which is called the vaccine-derived immunity, and the infection also giving immunity. So when we combine the herd immunity, which for COVID, I think people are working something like between 80 to 85%, something like that. So you can see now that Omicron has infected so many people, and therefore people are immune. So this is vaccine-derived, the infection-derived immunity, then you got vaccine-derived. So that's actually herd immunity. So the question people are asking that if that's actually happening, why we have to vaccinate? We have to vaccinate to protect ourselves because preventing severe disease. So we don't want to actually get long COVID. So the whole idea, we don't want to, we can argue that, nobody should vaccinate, everything be over. So I think the good news is that yes, the severity is actually low, number one, and herd immunity is actually getting slowly, gradually, and we are in different phase of pandemic altogether. But I think I see hope at the end of the tunnel, you know what I mean? But it will be very gradual.
Mm-hmm.
Thank you.
Thank you for that. Thank you for giving us some hope. Trudy, can I come to you? You have been at the absolute cold face of this, battling this on our wards now for almost 2 years. And I know that whilst you face many challenges, one of the biggest is trying to prevent nosocomial spread. Just simply because this is so highly transmissible, as Dr. Damani said. How have you and your staff been managing this?
We have been hugely challenged by hospital transmission of COVID. We've been challenged by the high community prevalence, as Anna, Paula and Dr. Damani have said. For example, yesterday's Public Health Agency report showed that there were 6,009 new cases regionally yesterday, and our catchment area had 1,433 cases per 100,000, which is exceptionally high. We're also challenged by our aged estate that doesn't comply with current, health building notes and health technical guidance. We have multi-occupancy bays, and sadly, as Anna Paula said, we have seen our patients, their families, and our colleagues hugely impacted by the effects of COVID. But we have been proactive. We try to eliminate risk where we can, so we might defer appointments if that's possible. We've looked at engineering controls, so we've looked at all the hierarchy of controls to try and implement safety measures. So we've looked at engineering. Our hospitals are mostly naturally ventilated, so we encourage opening windows, challenging in the very cold weather like this morning. We've had business cases in to improve our ventilation, so we have works going on in Forsyth, our emergency department, our haematology unit, our ENT outpatients, and many more works hoped and planned for in the future. And then we're looking at new technologies such as air scrubbers. So we work closely with Dr. Damani and colleagues from PHE England. And we are looking to purchase more HEPA filters, air scrubbers with ultraviolet light, new technologies that we hope will make a difference. Then there are things like how we work. So we've looked at the administrative controls. So screening of our patients. So when you come into the emergency department, you have a Lamera swab. If you're positive, you go in one pathway. If you're negative, you go in another. We test patients on a regular basis in the hospital to identify cases early and enable us to isolate and cohort patients. And in relation to that, we manage our COVID patients in cohorted areas, and everybody knows we've got 2 North, where our COVID positive patients are managed by a specialist team. Then we also look at physical distancing, again, challenging our hospital estate, but simple things like the patient on one side of the bed, and then the locker, and the same mirrored on the opposite side, so that we try to get that 2 metre social distancing. Simple measures like pulling the screens between patients where it's safe to do so, and patient masking all make a difference. It's important that we have appropriate signage on our wards so that people know what to expect when they're going in. And then education and training is really important. So we have approximately 14,000 staff who we've trained in the safe and effective use of PPE. And we developed videos when we couldn't do face-to-face training. And we've informed people about COVID, how it transmits, what treatments are now available. And then we share our lessons learned. So when we do have nosocomial transmission, we identify where the learning is and share that with our teams at our various forums. And then the importance of basic infection prevention and control standards, good hand hygiene, use of personal protective equipment, cleaning. And I have to have a huge thanks to our domestic staff who have gone above and beyond, cleaning up to 4 times a day of high touch surfaces, our nursing colleagues who clean equipment, our portering staff who work diligently bringing our samples down to the laboratory, and again, our patients who are working with us, wearing masks when they can, restricting movements throughout the ward. And again, we're trying to minimise bed moves between and in wards, all to help reduce risk of transmission. And then we've also implemented the use of personal protective equipment, something that was totally different from 2 years ago. It's probably one of our least effective control measures, but a very important one, and that we wear PPE appropriately, we don and doff safely. We were early adopters of universal masking and eye protection. We have our central donning and doffing stations, which helped support staff in the early stages and continues to, if they're donning and doffing. It helped with our training at the time. And then obviously it's important that we audit so that we can provide assurances, but also help with learning lessons and teaching. Many things we have implemented to try and help reduce the risk of healthcare associated infection, but it remains a daily challenge and everybody is working exceptionally hard to try to prevent transmission.
My goodness, Trudy, when you list it like that, I don't think people realise at all the absolutely extraordinary efforts that you and your IPC colleagues, and then every single member of our staff, the lengths that they have gone to keep our patients safe. It's absolutely phenomenal. And I suppose, Paula, can I ask you, is this the extent of this challenge? Is this something you've seen right across Europe as colleagues struggle to try and prevent the transmission of this highly contagious virus?
So let me start saying that, my heartfelt congratulations to Trudy. It's really amazing, right? That she lists all the measures. And if we count the number of hours, how many people were involved on that and the costs, and then we try to, you know, calculate the lives that were saved, right? Congratulations, it's really amazing. I wish most countries, most hospitals were doing like you were doing, Trudy. Unfortunately, we see that I think the situation in other countries, or let's say most of other countries, is that, so first, we start the pandemic with a situation where we have many healthcare facilities that are understaffed. So when we talk about the ratio between patients to health workers, that rate was already bad at the beginning. Another thing is job security for health workers, especially when they have to go on sick leave because they have a cold, because they have influenza. We know that before the pandemic, we had this approach of presenteeism. I just have I have to come because I don't have nobody that will cover my work. So this is how we start. And to add, unfortunately, the most important precautions in infection prevention control that are the standard precautions, right, is the welcome, is how you welcome patient into your unit, was never great, right? Health workers, they're better at applying when we are talking about transmission-based precaution, because they understand there is a risk of transmission. So then, so I know. But unfortunately, the standard precautions were not great. People were just, health workers were not really using the, you know, the extent of this powerful tool that we do have for many years, right? So this is how we start the pandemic. And then, you know, in 2020 was, you know, like we have many more severe cases. And I think when we start having the new variants, or the variants of concern, a year ago with the Delta variant, I remember that one of the things that we noticed that was remarkable, that in January, February last year, most of the health facilities that we were in touch, they were, of course, obviously tired, because Trudy just explained the extent of the task, right? They were absolutely tired. So they were, they decided not to implement syndromic surveillance among health workers, because that was the moment that we start the vaccination. And, you know, health workers, they have to be vaccinated, the risk group vaccinated. And unfortunately, there was a pause, or it's like we say, well, if people are vaccinated, we will have a different approach. And I think that this is something that we, infection prevention control, we try since the very beginning, not of the COVID pandemic, but since the very beginning of infection prevention control. Let's go back to Semmelweis. Regardless your vaccination status, regardless status of infection, the guiding principles of infection prevention control should be in place. And I think that this is something that fluctuates a lot in some countries, because health workers just refuse to get vaccinated. They have to say, okay, so we look at the status of infection among health workers, and we would do things differently. And I just want to emphasize that how important that this is a guiding principle in infection prevention control. Regardless your status of infection for any infectious disease, or regardless your status of if you had the disease or not, still, the guiding principle of infection prevention control should be applied consistently, right? It's not because you had measles in the past and then you have a patient that is admitted in your unit with measles, you say, I don't need to wear the protection. We don't do that. We have to be consistent. And I think that this is a good message that we would like to pass on, how to ensure that, you know, this extensive work that Trudy just explained to us, how we keep up, how we make sure that health workers understand that we are doing this to protect them, visitors also understand that we're doing this to protect them and also the patients. Because I think at the end, infection prevention control, this was perceived most of the time as the prohibition, right? That we want to prevent social contact. No, we never wanted that. We just want to ensure that it's done in a safe manner. Thank you.
Yeah. Can I add, Ruth, a couple of other points which Paula has said? I think as Paula has highlighted, that what we are talking over here is vaccine plus, because there are so many infectious diseases which are there. And I think when people think that I'm vaccinated and therefore I'm protected, and therefore they don't actually take the IPC precaution. And we've seen cases of, say for example, hepatitis B, when hepatitis B immunization were introduced, the number of needles taken went up. But they have to understand that it only provides protection hepatitis B, but not HIV and hepatitis C and things like that. I think the other thing also is that this COVID have learned a lesson. If you look at SARS outbreak, when the SARS outbreak was controlled in Asian countries, the standard precaution went down back to normal. That means low. COVID, I think, is a very different ballgame altogether. COVID has taught us one thing, that first of all, most likely, I think people will be getting vaccine on a regular basis. We don't know when, that we cannot predict because of the variant. And variant are going to change, this is the nature of virus, we cannot change it. So variant will come in future. The answer is just like predicting earthquake. It's going to happen, we don't know when, where, and what impact it has. It's just like that. So second thing we have learned also from COVID, that the vaccine do not provide transmission of infection, as the infection do not provide transmission of infection. So people are actually, who are vaccinated, they are getting breakthrough infection. People who are infected, they are getting second or third wave of infection. So I think what we have to understand now, vaccine plus standard precaution is now have to be embedded. This is what the COVID has taught us. And I think this is the way. So as I've told you, for the last 20, 30 years while we're working with Trudy, we try to implement simple basic hand hygiene, you know what I mean? And my children used to tell me, for the last 30 years, we've been training hand hygiene, people compare still low kind of thing. And this is my son who was a medical student. And he thought this is very, but I think people have to actually embed infection standard precaution is for their own safety, for the safety of patient, for the safety of the people who are for their own family, for the safety of the visitor. So I would say vaccine plus standard precaution is now new norms in IPC. And maybe most likely Trudy had to do less task in implementing those measures. So that's the silver lining of the COVID, I think, coming out of IPC.
Oh, so Dr. Damani, would you say then that the vaccine itself has played the key role in sort of shifting the whole direction of this pandemic? You hinted at it there, but what part will they play in the future?
I mean, vaccine is a game changer. Okay, so let me actually give you a small example. So say, for example, let's talk about Spanish flu. It's not doom and gloom, you know what I mean? That's the way I look at it. So let's actually talk about Spanish flu. Okay, so look at Spanish flu. Of course, I'm not comparing influenza virus with COVID. Okay? They are completely different kettle of fish in terms of epidemiology, in terms of all bits and pieces, they are different. If you look at Spanish flu, 1918, about 100 years ago, at that time, the population was approximately 1.9 billion to approximately 2 billion. The death rate was 50 to 100 million. Okay, that was the death rate. Now, of course, we cannot compare the situation about 100 years ago now. Look at current pandemic, okay? I'm not looking at the number of cases, I'm looking at the number of population. So our current population is 7.8 billion. But death rate is now approaching between 5.7 to about 6 billion, around that million. So it's quite less. So what was the difference? The difference was immunization, number one. Second bit, because we did not have immunization at that time. And second thing, better, of course, malnutrition was less, we are living in much better condition compared to First World War. The war was going on, so we cannot compare. But what the vaccine has really done is it prevented the severity of disease and death a big time. That was a game changer. Other game changer was, can you see the scientific community is absolutely remarkable. The amount, when the virus was discovered in terms of genomic sequence, developing the test to identify the virus and vaccine, that is the major learning. So I think there are a lot of silver lining to this cloud, you know what I mean? So I'm personally very optimistic that yes, we have gone through absolute hell, as Trudy have highlighted, and globally, we have seen this, it has caused absolute mayhem. But I think we have to learn a lot of things from there to actually learn these sort of things. So severity and death, especially. But also the other thing is that, if you look at the population currently is very vulnerable population, okay? That means we've got people who are living longer. So if you look at the comparatively death rate in about 100 years ago, which was not there. So we've got more morbidity. Unfortunately, I can say that we are living longer, but not healthier. So we've got a lot of comorbidity. So therefore, if you look at hospital, and Trudy will tell you that most of the patients, they are coming to the hospital, they are old, vulnerable, multiple comorbidity. So we are not actually fit around there. And the other thing which is also important, 2 years of pandemic, look at the amount of treatment and the disease and the global community coming together to those other things. So even people are getting infected, we've got much better tool available to treat and manage the infection. This all happened within last I would say a year, possibly 18 months, which is absolutely remarkable. So I think I'm really, yes, it was awful, but I think I'm not really giving people hope. This is the reality. And we have to live in hope. It will end. I can promise it will end, but the virus is not going to go away. Okay, we have to live with the virus. So I think, and second thing, I also just want to, the Trudy has just absolutely tremendous job. I think our trust have just busted their guts out. They've done more than what we can do in the very difficult circumstances with low staffing level, you know what I mean, which we were hit all the time, you know what I mean, and we were not different, as Paula highlighted, it's the situation worldwide. Our infrastructure, hospitals has been really, really old. They are not actually fit for any pandemic, and this is not our hospital, it's just our hospital worse than the other. But lots of hospital and healthcare facilities are not fit for this kind of thing. So I think these are all the things come out, and when we have what we call the postpartum of this pandemic, there were a lot of recommendations come out, at different levels. So I think yes, it is disaster, but I think we've learned a lot,
I think it's interesting you say, Dr. Damani, that the vaccine has been a game changer in this. And I wanted to ask about Paula, the World Health Organization is very strong on vaccine equity, and your Director General has said if we end the inequity, we end the pandemic. What are, just as you're describing this, Dr. Damani, what are the implications if we do have outbreaks of new strains, say in future, in unvaccinated populations? Will that set all of us back?
Thank you for your question, Ruth. So as Dr. Damani has explained, so the vaccine was definitely, completely changed the game. Unfortunately, access to vaccine was not equal. And to add to that, also perception of those who are going to receive the vaccine was not standard, right? Some people really wanted to get vaccinated. Some people still don't want to get vaccinated, right? And I think we moved to this, I think because we all have this anxiety that we want to go back to normal, and then we see that someone that refused to take the vaccine and said, that person is preventing me to go back to my normal life. And I think that we have, in 2022, we really have to open this dialogue, right? And give people the chance to explain why they do not want to get vaccinated. Because sometimes when we talk about equal access, imagine the mother of 4 children that works and has, to do all the logistics, taking kids from the kindergarten, school, and still had to organize, and then the vaccines cannot be organized in the same day. It is challenging. And in that case, for that woman, as not exigency because I don't trust the vaccine, is just, can someone help me? Right? So I think when we talk about equity, as Dr. Tedros has said, it's really about, you see, so many countries, so many continents, especially with the, the African continent, that the vaccine access was unfortunately very low. And if we have a new variant circulating in 3 months or in 7 months or in 8 months, everything we learned, we implemented, let's say here in Europe, we gain experience, right? We know at least by, you know, how hard it was to implement a mask policy at, you know, at community level, how hard was and how complex was to explain to people to maintain physical distance. So I don't think that if there is a new strain circulating and we still have high levels of vaccination, I don't think it set us back. It remind us, okay, I know, I remember, I can do this. This is in my control. I can help with that. So I think that this is a SARS is not a friendly virus. Was never a friendly virus. We knew, right? Everybody recall from 2003 that was this fear. I remember I was working in a hospital at that time. So I remember how was, you know, the discussion, the preparations, and luckily in the hospital I work in Brazil at that time, we got only one patient, but was sufficient, right, to give us, you know, to open our eyes and say, wow, you know, it can be very challenging. So we know the virus is dangerous. The virus can mutate because it's part of its, you know, the way that the virus is composed. It's not unusual. It's not unexpected. It's going to happen. So for those who are at the group, a risk group, get vaccinated. You know, don't miss the opportunity. Help, you know, us, you know, to fight this virus. For those who are still wondering, should I get to talk with your health provider, have a conversation, but an honest conversation. Be ready to listen. Also be ready to speak up your concerns. And the other, right, the health provider, also, you know, take the time. I know it's challenging, but take, you know, that 5 minutes to truly listen and try to engage with this person at individual level, because we can change this exitancy, right? By feeding people with information, by correcting fake news, right? So we still have, you know, lots to do. And last, if, you know, like we need to, the word of this pandemic is solidarity. Trudy mentioned about, I paid, you know, attention when she was telling about the area to do the donning and doffing. This never happened in healthcare settings. We never really pay attention how my colleague is putting the mask on, or, you know, we were always good at observing and say that person is not doing right. But when we are together on that, it's really solidarity, because in healthcare, it's not only one person that is improving the quality of life of an individual. We are a big team, and we need really to exercise solidarity and understand that, you know, like, it's my turn, I get the vaccine, because then we can move the global supply of vaccines in a way that countries that could not afford at that time, when they receive the vaccine is not expired, or they have a short shelf life for the vaccine. So yes, we have, you know, to ensure equity, but we have to strengthen our solidarity. We need to get out of the pandemic closer as a group, because I think we went through a lot together, and we really saved a lot of lives together. Thank you.
Trudy, I'm just wondering, we've talked a lot here today about COVID-19. What about all the other infections that we used to worry about pre-COVID, like C. difficile and MRSA? Have they gone away, or are they still challenging you and your team?
Ruth, they are still a challenge. You know, infection control has to be consistent. We have to have consistent high standards to prevent transmission. We have to prevent antimicrobial resistance by good antimicrobial stewardship, which will help Clostridium difficile. But as we said, you know, even just back to COVID, it is important that we do have the vaccine plus message, that vaccine plus hands, face, space, and fresh air. But all of the measures that we do for COVID will also help other infections such as MRSA, gram-negative bacteremias, and Clostridium difficile. And we are still challenged with those. It's important that we still look at how we manage our peripheral lines, how we manage our central lines, our urinary catheters. It's important we look at antimicrobial stewardship, good environmental cleaning, equipment management, and ensure that our standards are high. We do have an ongoing problem with Clostridium difficile, and this is something that other trusts, hospitals, and have seen worldwide. So in relation to that, we are doing projects such as joining the quarantine study to identify thresholds associated between population antibiotic use and resistance rates, and therefore maybe Clostridium difficile. But it is, we work constantly with our staff in relation to maintaining good basic infection prevention and control. The basics are always there and always important. And the consistency in those are important. And I do have to thank all of our staff for consistently coming into work every day to do their best in the most challenging circumstances, when they have to wear PPE, including FFP3 masks, visors, gowns. All makes it so much more challenging. As Paula said, and Dr. Damani's highlighted, staffing levels are not always what we would want them to be. We have vacant posts, we have sickness absence, and everybody comes in and does their best every day. But we are still challenged with nosocomial transmission of COVID, and we still have to be mindful of MRSA, MSSA, Clostridium difficile, ASBL, all of those things that we've talked about for many years are still and will continue to be challenged.
Can I come back to you, Anna Paula? How do we take all of these lessons that we've learned through the pandemic and make this year a better one?
So, Ruth, I like to lower a little bit the bar here and say that we identified many lessons. Please don't get me wrong, but I want to be careful on exactly what we learn. I think we identified lots of lessons. I said many, I said about the staff patient ratio, right? What we identify is that if we don't do something serious about this, right? It's, for disease X, for the MRSA, for the Clostridium, right? Still, the situation is not going to improve, right? So we have to look at what are these measures, aha moments that we had during the pandemic, and turn this into an opportunity to change, right? So if you close your eyes and you remember when you start cycling, right? That very day that you dare to go, without any support and get the wind, right, on your face, right? It's so marvelous. This is what we have to get out of this pandemic, right? That we did have many ahas moments that now, perhaps that's the way we should go for it. I think, as I said, the word of this pandemic is solidarity, and we need to, nurture this feeling, right? That is, we exercise solidarity with my colleague, I exercise solidarity with the patient and with the family, and this is it's hard because it's beyond empathy, right? Solidarity goes beyond empathy. And we have to find the balance on how we can live, in harmony, out of, the losses we had and those things that we would like to be different for next time. Because if I go back to the story of a patient and to health worker ratio, we knew this was not great before the pandemic. During the pandemic, we saw some increase, and we saw that my colleague that used to work in the, let's say, in a clinical ward, came to help me in the ICU, right? So we saw this, trying to improve the capacity of health workers in a ward, right? So mechanisms for surge capacity. So what is the lesson we identify of this is that we all have a role to play, but we need to make sure that certain numbers are secure and they are, they become the new normal. And the new normal should be, the ratio of patients for, health worker might be this. The compliance to standard precaution should be at least 60%, right? We do standard precautions, let's say, in a sense, every time we're outside, when you cross the street, right? You always assess your risk. Can I cross or not? We have to make sure that this is the new normal, right? Because again, perhaps we learned something. I don't think we learned that much, but we identified a lot of lessons. And for those lessons identified that we had the aha moment, this is where we have to build and continue. Because life, it's always better. Life, I think it's the fate of life. It's always to get better every day. Of course, that very day, sometimes I look back and I'm like, oh, yesterday was so much better. But in 5 days, I look back and I know that 5 days before, it was already great. So we really have to have this feeling that, yeah, life, it's always better. I'm going to exercise solidarity, and I will make sure that all, those experiences that I had during the pandemic, the aha, that make me understand something, I will try to implement, because this is how we should start this new normal. It's going to be great. It will be a challenge, but it's going to be great.
That's a good way to end it. Anna, Paula, Trudy Reid, Dr. Damani.
Yeah, I just want to add one thing, Rudy, that what Dr. Damani said, that yes, the old good times, right? So if as a health workers, we have to be vigilant for the new kids in the block, right? On the block. So maybe a new variant or maybe new virus, right? But also be vigilant of the old and good friends, like they always been with us for the last 20 years, because they also can make the story change, from one moment to other. And we do have the tools to prevent them and control them. So, have fun with the new kid and also with the old kid, because it's that's how life will be, the new normal.
Yeah,
thank you.
And I just want to thank the staff in the Southern Trust, everybody, from porter to consultant to senior management. I think they've done a tremendous job in very, very difficult circumstances, you know what I mean? And especially Trudy, I think, who's leading the whole thing. And I think they've done a tremendous job. We are doing our best, you know what I mean? We could have done better, and then, the way things are at the moment, everybody is struggling. So I think I just want to thank all the staff in Southern Trust, and especially Trudy Reid and team, that they are doing tremendous job, the IPC team. Thank you.
Anna, Paula, Trudy Reid, Dr. Damani, thank you very much.